Good evening, Dr. Phil here. Today we'll be discussing on perioperative hypothermia part 1. Normal body temperature regulation. Normal core body temperature is 37 degrees Celsius or 98.6 degrees Fahrenheit. Temperature control is regulated by the body to within 0.2 degrees Celsius. Core body temperature represents the temperature of the deep thoracic, abdominal and central nervous system tissues. It is usually 2 to 4 degrees Celsius warmer than skin temperature. If body temperature is outside of this inter-threshold range, the hypothalamus initiates homeostatic and behavioral mechanisms to return the body to normothermia. Strict temperature control is important for normal organ, enzymatic, and cellular function. Thermal sensors. Heat and cold sensitive cells are located at the hypothalamus, brainstem, spinal cord, deep abdominal tissue, thoracic tissue, and the skin. Afferent fibers for cold receptors are the A delta fibers, and for the warm receptors, afferent fibers are C fibers. Both warm and cold receptors communicate with the preoptic nucleus of the anterior hypothalamus via the lateral spinothalamic tract, or the cranial nerve 5 for the head and neck. Central thermal regulators are the hypothalamus and the spinal cord. When the patient is in hypothermia, this is detected by the thermal sensors and transmitted via the afferent fibers to the central thermal regulators as mentioned before, and efferent responses to hypothermia includes behavioral modification such as wearing more clothing and relocating to a warm shelter, vasoconstriction, which is mediated by alpha-1 adrenergic receptors, shivering, increased mechanical work results in heat produced as a byproduct. Metabolic rate can increase by up to 6 times basal metabolic rate. Non-shivering thermogenesis occurs in neonates. This is mediated by beta-3 adrenergic receptors in brown adipose tissue. Brown adipose tissue is more abundant in infants. This has little significance in adults. This type of adipose tissue has increased number of mitochondria that increases lipid oxidation to generate ATP and heat. Metabolic heat is produced without muscular activity. When the patient is in hyperthermia, the body responds by sweating, vasodilation, and behavioral changes in an attempt to reduce body temperature. The term threshold refers to the temperature at which an effector is activated. The term gain refers to the rate of response to a change in temperature. Normal body heat distribution. Body heat is distributed at the periphery and the central core compartment. 33% of body heat lies in the periphery. Temperature here may undergo wider fluctuations compared to that in the central compartment. It is therefore essential to measure core temperature. The central core compartment comprises the brain and the organs of the trunk. 66% of body heat lies within the central core compartment. Here, temperature is maintained between 36.5 and 37.5 degrees Celsius. Unintended perioperative hypothermia refers to a core temperature of less than 36 degrees Celsius perioperatively. Up to 20% of patients experience unintended perioperative hypothermia. One classification of hypothermia: mild hypothermia 32 to 36 degrees Celsius, moderate hypothermia 28 to 31.9 degrees Celsius, and severe hypothermia less than 28 degrees Celsius. Mechanisms by which patients lose heat during anesthesia includes radiation, convection, evaporation, conduction, and respiration. Radiation refers to transfer of heat via the emission of infrared waves. Heat energy is lost from the body via transfer of infrared radiation from it to a second system that is not in direct contact with it and that has a lower temperature. Radiation is the most important mechanism for heat loss. This may account for at least 50% of heat loss. Thermal radiation refers to electromagnetic waves emitted from all matter that has a temperature greater than absolute zero. Thermal radiation travels in straight lines. Surrounding matter absorb radiated heat. Thermal radiation can be reflected. Heat loss via radiation is exacerbated when the patient is surrounded by cool objects and prevented from receiving radiant heat from the environment. The body is a highly efficient radiator that transfers heat from hot to cooler objects. Heat loss via radiation is proportional to the fourth power of the temperature difference between the body and its surroundings. Heat loss via radiation is also exacerbated when the body is forced to heat cold infused fluids up to 37 degrees. 1 liter of crystalloid infused at room temperature or 1 unit of blood at 4 degrees Celsius lowers core temperature by 0.25 degrees Celsius. 30 ml per kg of crystalloid infused at room temperature will decrease core temperature by around 0.5 degrees Celsius. Heat loss via radiation is minimized by minimizing the temperature gradient between the patient and the surroundings, for example by using forced air warming or increasing the ambient temperature. Reflective blankets also minimize heat loss via radiation. Next is heat loss via convection. Convection refers to mass movement of liquid or gas from a hotter region to a cooler one. Heat energy is lost from the body via air movement across an exposed area, acting to remove previously warmed air and bring unwarmed air into contact with it. Convection accounts for up to 30% of heat loss. The air in the layer close to the body, if trapped, it acts as an insulator that limits conductive heat loss to surrounding air molecules. This air is warmed by conduction and rises as its temperature increases and its density decreases and is carried away by convection currents. Air currents disrupt this air layer. This reduces heat insulation and increases heat loss. In the operation theatre, there is increased air exchanges compared to non-operation theatre hospital settings, 15 times per hour versus 4 times per hour respectively. This increased amount of air exchanges increases heat loss via convection. Heat loss via convection is exacerbated when a large body surface area is exposed to convection currents, particularly in laminar flow theatres. Heat loss via convection is proportional to both the exposed body surface area and the degree of air movement. Heat loss via convection is minimized by passive insulation such as clothing, blankets, and surgical drapes that trap warm pockets of air around the patient, preventing them from moving away. Forced air warmers also minimizes heat loss via convection. Heat loss can occur via evaporation. When evaporation occurs, there is loss of heat energy from the body via the latent heat of vaporization that is required to be taken from it as liquids in contact with the body move to the vapor phase. Latent heat of vaporization is lost and the body cools when moisture on the body surface evaporates. This accounts for 15 to 50% of heat loss. Some authors quote 20 to 25%. Heat loss via evaporation is accelerated during anesthesia if there is a large moist surface area open to the atmosphere. For example, during evaporation of skin preparation fluids, during evaporation from exposed body cavities or mucosal surfaces, during major intra-abdominal surgery, intrathoracic surgery, reconstructive plastic surgery, or major orthopedic surgery, when there is excessive sweating, and during humidification of any dry respiratory gases. Heat loss via evaporation is minimized by covering open body cavities and wet surfaces, increasing ambient humidity, and by warming and humidifying inspired gases such as by using a HME or circle breathing systems. During conduction, heat loss occurs from the body by direct transfer of that energy to an adjacent system that is in direct contact with it and that has a lower temperature. This accounts for about 5% of heat loss. The rate of heat transfer depends on the temperature difference between the two media and the heat conductivity of the materials. Conduction is not a significant cause of heat loss during normal circumstances. Heat loss by conduction during anesthesia is increased if the patient is lying unprotected on an efficient heat conductor such as a metal table, or when non-warm IV fluids are used. During respiration, heat energy is lost from the body due to humidification 8% and due to warming of inspired air 2%. Heat loss occurs via evaporation and conductive losses of inspired air. This accounts for 5 to 10% of heat loss. Heat loss via respiration is minimized by using heat and moisture exchanges and by warming and humidifying inspired gases. Causes of heat loss during anesthesia. Examples include loss of the behavioral response to cold, impaired thermoregulatory heat-preserving mechanisms. Anesthesia reduces the threshold at which thermoregulatory vasoconstriction and shivering is activated. The inter-threshold range is widened from 0.4 to 4 degrees Celsius. These thresholds are further reduced in elderly patients. Anesthetic-induced peripheral vasodilation results in diversion of core blood to the periphery and redistribution of core heat from the core to the periphery. Exposure during surgery increases heat loss. Prolonged procedures, having a large, moist surface area open to the atmosphere, and limited access for external body warming increases the risk of inadvertent hypothermia. Use of unwarmed IV or irrigation fluids. Fluid depletion prior to anesthesia results in poor peripheral perfusion and impaired heat distribution. Regional anesthesia also increases heat loss. There is a reduction in shivering and vasoconstriction threshold below the level of the block due to reduced efferent input from the peripheral thermal sensors. For example, there is absence of cold signaling from skin sensors in the legs due to neuraxial anesthesia. This is interpreted centrally as relative leg warming, and this reduces shivering and vasoconstriction thresholds by about 0.6 degrees Celsius. Redistribution hypothermia can occur with regional anesthesia. Regional anesthesia induces vasodilation at the blocked body area. This results in cooler peripheral blood redistributing to the core. Vasoconstriction above the level of the block can compensate to some degree. Certain sedatives and analgesics such as propofol, alfentanil, and pethidine given during regional anesthesia impairs thermoregulatory control further. The pediatric population. Compared to adults, the pediatric population have increased heat loss. Children and neonates have a higher surface area to volume ratio and reduced insulating adipose tissue. Thus, they tend to lose more heat than adults via conduction and radiation. Infants have an immature hypothalamic thermoregulatory capacity and high resting vagal tone, thus they are less able to vasoconstrict. General anesthesia lowers the threshold for vasoconstriction, and this increases heat loss. Compared to adults, the pediatric population has reduced heat production. During general anesthesia, there is a reduction of metabolic rate by up to 20% in pediatric patients. General anesthesia reduces the threshold for other compensatory mechanisms, including non-shivering thermogenesis. Mechanical ventilation reduces the heat produced from the work of spontaneous breathing, which is a significant source of heat production amongst neonates. Risk factors for unintended perioperative hypothermia in the pediatric population includes young age, length of surgery lasting more than 30 minutes, major surgery, and temperature less than 36.5 degrees Celsius prior to induction of anesthesia, etc. Phases of hypothermia during anesthesia. There is phase 1, phase 2, and phase 3. During phase 1, there is redistribution of body heat and reduction in core body temperature occurs immediately post-induction of general anesthesia, as there is a loss of the ability of the body to maintain a core periphery temperature gradient, primarily due to anesthesia-induced vasodilation. The tonic vasoconstriction that normally maintains core to periphery temperature gradient is inhibited by anesthesia. Vasodilation causes redistribution hypothermia. Warm blood from the core circulation reaches the peripheries, and cool blood from the peripheries enter the core circulation. The warmer periphery caused by general anesthetics results in a greater risk of the patient losing heat to the operation theatre environment. Vasodilation is caused by direct effects of anesthetic agents and indirect effects of a lowered vasoconstriction threshold. The average temperature of these two compartments is the new attained temperature. Phase 1 lasts for 30 to 45 minutes. The temperature reduction is 1 to 1.5 degrees Celsius. This phase is drawn passing between 37 and 35.5 degrees Celsius during the first hour under general anesthesia. To prevent phase 1 hypothermia, pre-warm periphery body parts prior to induction, for example by using forced air heating until the core and periphery are at the same temperature. However, warming the periphery to 37 degrees Celsius may be uncomfortable for the patient. During phase 2, a more gradual reduction in core temperature occurs following phase 1. The duration of phase 2 is 2 to 3 hours and the temperature reduction is 1 degree Celsius. Phase 2 occurs due to heat loss by radiation, convection and evaporation exceeds heat gain determined by metabolic rate. There is a negative heat balance that results in hypothermia. General anesthesia causes metabolic rate to reduce by 15 to 40%. Evaporative heat loss is exacerbated during major abdominal surgery. Heat loss during this phase is represented as a line with a shallower gradient over a further 2.5 hours. The gradient of phase 2 hypothermia can be altered by the use of blankets, warm fluids, warm air heating, HME, etc. Passive heating reduces the slope of phase 2 and active heating causes a rise in the temperature back towards 37 degrees Celsius, and this can be drawn as a warming line. Phase 3 hypothermia is represented as a plateau phase where heat loss equals metabolic heat production. The final plateau line is at a temperature of about 34 degrees Celsius. Phase 3 occurs when vasoconstriction is triggered in a patient under general anesthesia that is sufficiently hypothermic. Anesthesia widens the thermoregulatory range. Protective mechanisms against hypothermia do not begin until the core temperature falls by 3 to 4 degrees Celsius. Altered thermoregulatory mechanisms begin to act in phase 3 to stabilize body temperature if the patient is left untreated during general anesthesia. However, if neuraxial anesthesia is used concurrently, compensatory vasoconstriction against hypothermia is lost. The greatest risk of hypothermia occurs during combined regional and general anesthesia. In the pediatric population, the slopes of phase 1 and 2 hypothermia are steeper in younger age groups as they have increased heat loss and decreased heat production. Phase 3 is characterized by a rewarming slope caused by non-shivering thermogenesis. Clinical implications of hypothermia. Cardiorespiratory effects. There is a reduction in cardiac output and oxygen delivery. The oxygen hemoglobin dissociation curve shifts to the left, resulting in increased oxygen affinity by hemoglobin and reduction in oxygen delivery. There is increased oxygen consumption. This increases during mild hypothermia. Increased catecholamine release results in increased arterial blood pressure and myocardial workload. Oxygen consumption may increase by up to 500% during shivering as the patient rewarms. This may increase the risk of myocardial infarction. However, some studies indicate that perioperative myocardial infarction is unrelated to shivering, as oxygen consumption rarely increases beyond 2 times, and shivering is inhibited by hypoxia, which is commonly seen in patients with poor cardiac function. During hypothermia, there is increased incidence of arrhythmias, such as first, second, and third degree heart block, sinus and junctional bradycardia, idioventricular rhythm, premature atrial and ventricular beats, atrial and ventricular fibrillation, and Osborn waves. Osborn waves are prominent J waves at the QRS-ST junction electrocardiogram, seen in 80% of patients with hypothermia. However, Osborn waves are not specific for hypothermia and can occur with hypercalcemia, subarachnoid hemorrhage, cerebral injuries, myocardial ischemia. Osborn waves have no diagnostic value in hypothermia. During hypothermia, there is increased incidence of myocardial infarction. Reduction in core temperature to around 35 degrees Celsius is associated with a 6% incidence of myocardial ischemia or arrhythmia, compared to 1% in control groups. Perioperative hypothermia increases morbid cardiac outcomes by increasing myocardial oxygen demand and reduction in oxygen supply, via increased plasma catecholamines, increase in blood pressure and heart rate, and reduction in available oxygen for tissues by increasing oxygen binding to hemoglobin. Increased blood viscosity increases the risk of venous thromboembolism. There is a 3 times increase in the incidence of morbid cardiac outcomes. With regards to hematological functions, there is a reduction in platelet function and coagulation cascade function. INR and partial thromboplastin times are increased. However, this may not be evident if the coagulation profile is run at normal body temperatures. Fibrinolysis is increased, and this causes clot destabilization. There is increased intraoperative blood loss and blood transfusion requirements. Body temperatures at 35.5 degrees Celsius have been shown to increase the relative risk of transfusion by 22%. Metabolic effects of hypothermia and their effects on drugs. There is a reduction in metabolic rate. Metabolic rate reduces initially by 6 to 7% for every 1 degree Celsius drop in core temperature from normal, but this relationship changes as hypothermia worsens. There is a reduction in rate of enzymatic reactions. All reactions of intermediate metabolism are reduced at core temperatures below 34 degrees Celsius. There is a reduction in MAC by 5% for each 1 degree Celsius drop in core temperature below normal. There is a reduction in hepatic and renal function. Diuresis may occur due to failure of active reabsorption of sodium and water. This results in increased duration of effects of most drugs. The increase in tissue solubility of volatile anesthetics results in delayed recovery. Reduced hepatic metabolism results in prolonged actions of propofol and opiates. Reduced hepatic and renal blood flow results in reduced metabolism and excretion of drugs, thus prolonging drug effects. Hypothermia increases neuromuscular block duration due to reduced hepatic metabolism, reduction in the rate of Hoffman degradation, changes in volume of distribution, altered local diffusion receptor affinity, pH changes at the neuromuscular junction, cooling of the various components of neuromuscular transmission. Duration of action of neuromuscular blockade at 35 degrees Celsius is extended by 50%. Hypothermia increases acidosis. Hypothermia increases blood sugar levels. This may occur as there is a reduction in glucose utilization. Creatinine kinase, creatinine and potassium is increased if shivering occurs. Physiologic responses towards hypothermia in neonates. When neonatal hypothermia occurs, there is an increase in sympathetic response. This results in pulmonary vasoconstriction, increased pulmonary arterial pressure, increased right to left shunting, and hypoxemia, which worsens pulmonary vasoconstriction. Hypoxemia increases anaerobic metabolism and results in increased lactic acid. Increased sympathetic response also increases peripheral vasoconstriction, and this increases lactic acid production. Increased lactic acid production exacerbates pulmonary vasoconstriction. CNS effects of hypothermia. There is a progressive worsening of mental function. EEG will record no cerebral activity at a core temperature of 18 degrees Celsius. However, the brain is still metabolically active and shall exhaust energy substrates after 25 minutes. CMRO2 is reduced. The relationship between CMRO2 and temperature is linear rather than exponential. The gradient of the line changes at about 27 degrees Celsius. At the brain temperature of 37 degrees Celsius, each 1 degree Celsius drop in temperature is accompanied by a fall in CMRO2 of 6 to 7%. At 27 degrees Celsius, each further 1 degree Celsius drop in temperature is accompanied by a fall in CMRO2 of 2%. CMRO2 will be 30% of baseline at 27 degrees and 10% of baseline at 17 degrees Celsius. Hypothermia can trigger shivering. The effects of shivering includes increased oxygen consumption by 50 to 400%, increased post-op pain. Shivering makes monitoring unreliable, such as ECG, NIBP, IABP, SpO2, etc. Shivering increases CO2 production, catecholamine release, and cardiac output. Shivering can occur independently of hypothermia but should never be treated independently of hypothermia. Treatment of shivering is to warm the patient. Pharmacological options includes petidine 25 mg, clonidine 150 mg, or doxapram 100 mg. These drugs work by lowering the shivering threshold, and this lowers metabolic heat production. Pharmacologically treating shivering would compound hypothermia if the patient is not simultaneously being warmed. Surgical outcomes. Hypothermia results in impaired wound healing secondary to reduction in subcutaneous wound tissue blood flow, reduction in oxygenation, and impaired immune function. There is impaired neutrophil function and reduction in superoxide radical production. Hypothermia increases post-operative surgical site infection by up to 3 times. This is independent of the SSI risk associated with perioperative blood transfusion. Hypothermia increases length of hospital stay. Hypothermia increases the risk of pressure sore development. Hypothermia reduces patient satisfaction and increases hospital costs. Regarding the pediatric population, many effects of perioperative hypothermia discussed above in adults can be extrapolated to children. In neonates, hypothermia results in increased noradrenaline release, increased oxygen and glucose uptake, increased metabolic acidosis, pulmonary vascular resistance is increased, right to left shunting is increased, and reduction in tissue perfusion and oxygen flux occurs. Hypothermia results in delayed recovery from anesthesia and increased risk of post-operative respiratory depression. A side note on beneficial effects of hypothermia. Hypothermia reduces oxygen consumption. Reduced metabolic rate results in reduced oxygen demand, and this may benefit organs with high oxygen consumption such as the brain and myocardium, as aerobic metabolism may continue longer in the face of reduced oxygen supply. Hypothermia reduces inflammatory mediator production. Reduced enzyme activity results in reduced synthesis of these inflammatory mediators. Examples of therapeutic use of hypothermia includes cardiac arrest, surgical repair of aortic aneurysms, treatment of asphyxiated neonates, treatment after brain trauma, and after intracranial aneurysm surgery. These are my references.